Good afternoon, everyone. Welcome to our first fall Yale Sleep Seminar series of 2024. I hope everyone had a good summer. My name is Ritika Thapa. I'm one of the faculties here at Yale. And before I introduce our today's speaker, just some brief housekeeping announcements. Please take a moment to ensure that you are muted. In order to receive the CME credit for attendance, please see the chat room for instructions. And if you have any questions or comments during the presentation, please use the chat room, or you can unmute yourself at the end of the talk and ask questions, and I will also moderate the session. Recorded versions of these lectures will now be available on YouTube after 2 weeks of the presentation. And today, I have the pleasure and honor of introducing Dr. Karin Johnson. She received her medical degree from University of Chicago. She then completed her neurology residency from Brown University and her sleep medicine fellowship from Harvard University Beth Israel Medical Center. She's currently a professor of neurology at UMass School of Medicine, Bay State, and vice chair of academic affairs for Department of Neurology and medical director also of Bay State Health Regional Sleep Program in Springfield, Massachusetts. She's also sleep section chair of the American Academy of Neurology and vice president of the Save Standard Time, a volunteer-run nonprofit advocating for permanent standard time, and co-chair of the Coalition for Permanent Standard Time. And she has done a lot of advocacy work on this topic. As I was going through her CV, there was a lot of them, and has also received many advocacy awards for that. So thank you so much for doing that. Dr. Johnson has also lectured in courses in sleep disorders nationally on several topics and primarily focused on sleep apnea, PAP, and IV titrations, and on importance of permanent standard time. She has received many awards, also several grants, and has authored many publications, including various guidelines that we all use, and has also developed various educational curriculum. She has also held leadership position in many national societies and is a strong advocate for women faculty leadership in medicine, and has served on the editorial board of many prestigious journals. And thank you so much for being with us and giving a great kickstart to our fall seminar of 2024. Dr. Johnson, and without further delay, I would like to hand it over to you to share your expertise on recognizing and treating central sleep disorder breathing subtypes. It's a long topic, so good luck. Thank you.
Hi. Well, thank you very much. I don't get money for anything, so no disclosures. Here's the code. There's a lot of material in this as I was putting this talk together. Some of the slides I'm going to go quickly over, but I left extra content in the slides. So if anyone wants to get a copy of it afterwards to see all the points, please reach out to me. But we're gonna kind of go over what is sleep apnea, central sleep apnea, why does it happen, how can we recognize it, and how can we treat it. Dr. Robert Thomas did share some slides with me that I used / adapted for a few of the things. So those are notated on the bottom. So again, starting with kind of the what and why. So when I think about central sleep apnea, I really have a big division up front of, is this more of a rhythmic pattern of central sleep apnea or more of a irregular pattern? So the rhythmic ones, we tend to see more in non-REM and are really driven by a response to sort of the carbon dioxide levels. And a lot of these patients do have low CO2 levels, but sometimes we do still see it in people that are hypoventilating. And again, we'll talk about why that might happen. The irregular pattern tends to be more of a problem at the central level. So narcotics suppressing it, brainstem lesions. Sometimes we see it in other sort of neuromuscular disorders. And often there's hypoventilation happening in these patients as well. When we have the more periodic ones, we can break those down further into a sort of short cycle, what we might see more often with high altitude or treatment emergent central sleep apnea, or more long cycle, which we refer to as Cheyne-Stokes respiration, where the classic is that that's associated with congestive heart failure. We then have what we probably see the most often in terms of central sleep apnea of treatment emergent central sleep apnea. I strongly encourage that term versus complex sleep apnea because it's really important to know, is there central sleep apnea baseline or is it only coming out with treatment? So, I like central sleep apnea that is persistent with treatment, or obstructive sleep apnea baseline with treatment emergent central sleep apnea. It's really good to know because that then really changes what the possible treatment options are. The most classic is that this occurs with PAP therapy, but we also see it with oral appliances, hypoglossal nerve stimulation. And this may be that there's more of the central component at baseline. It was just sort of masked by the obstruction, and it sort of comes more apparent once the obstruction goes away. But we'll also talk about why the pressures itself can be a factor. And if you note these sort of green markers for central apneas here, you can see they're only starting to occur as we get to higher levels of CPAP, and even worse when we get to BiPAP. The other thing you'll see is they're basically essentially only happening in non-REM, and they stop in REM, and that's a very common pattern. So some of the why that we do this, there's a lot of different centers and reflexes that go into our control of breathing. But essentially in sleep, and especially in non-REM sleep, we have carbon dioxide levels that are the main controllers, and they feed in through the aortic and carotid bodies, which is looking for basically the CO2 in the blood, or the oxygen levels as well. But it's important to remember in the central chemoreceptors that CO2 is taken up by the cells and then is sort of measured as the pH in the cells, which is a little bit different than the tension of oxygen in the blood. And we'll talk about why this matters. I mentioned before that central sleep apneas almost always occur in non-REM, but they can occur in REM. Usually in normal people, we'll see a couple of short ones, and that's very normal. But if you ever see a pattern like this with lots of centrals in REM, that is not typical. That should raise red flags. In this case, it was a case presentation of a person with Chiari malformation. So certainly if you're seeing these more typical ones, thinking about brain imaging could be really important because this is really rare. So often we're seeing these central apneas because of sort of this response to carbon dioxide. So essentially, if the carbon dioxide level is high, it tells our body to breathe more. And if our carbon dioxide drops below a certain level, which we call the apnea threshold, it says you don't need to breathe. And then while you're not breathing, the carbon dioxide builds back up, and eventually you restart breathing. This apnea threshold changes based on wake or sleep. And so it's usually a few millimeters of mercury below sort of the base sleeping CO2 level. And if it's higher, so if it's only 2 centimeters below, it doesn't take much. If you overbreathe a little, like with an arousal or something, it doesn't take much to drop below that level. So people where their apnea threshold is higher are more likely to go into apneas. And that may be one reason why some people are more apt to it. The other thing is, again, because these apnea threshold changes right at sleep, and because other things tend to happen at sleep transition, like changes in ventilation drive, or if you have an arousal and suddenly hyperventilate with the sympathetic response with the arousal, you can very easily sort of overbreathe, get below that threshold, see that post-arousal central sleep apnea. And then once the CO2 comes back, then it sort of stabilizes. And you may see a single central sleep apnea after an arousal, but sensitive people, you'll see kind of an ongoing, usually rhythmicity for a few cycles before it goes away. The way I like to explain this concept of high loop gain, which is this oversensitivity to our carbon dioxide levels, is sort of the thermostat metaphor. So essentially, if your thermostat is working well, it just always says, you're 72 degrees and everyone's happy. But if it's too tightly set, if suddenly it gets cold and the radiator comes on and it gets it too hot, so then the air conditioner comes on, so then it gets it too cold. You're getting this constant overshoot and undershoot. And so patients, when they hear central sleep apnea, they freak out and they go, oh my God, my brain's not working, I'm gonna die. I tell them, actually, your brain's working too well. You're having too good of a response. Your air conditioner, your heater are working too well. It's just oversensitive. And it's sort of, providing this instability for at least the majority of these periodic cases. So I'm going to briefly touch on some of these aspects of plant gain and mixing gain and controller gain, which all can be reasons why you get this sort of exaggerated response. So plant gain is essentially that a small change in ventilation will cause a larger change in CO2, and basically lung volumes can be a reason for this. And in one study that looked at people with Cheyne-Stokes respiration, they had a higher plant gain than people without Cheyne-Stokes respiration. I love this one. So again, if you think of your bodies responding to your CO2 levels at the carotid bodies and then at the central level, if they are telling you to breathe at different rates, then you can get a cyclic pattern. And so this was a modeling exercise to see, okay, if one's saying breathe at this rate and one's saying breathe at, a slightly different rate, what will happen? And what they found was that if you had a higher central gain and a lower peripheral gain, you'd end up with a long cycle. But if you had the opposite, you ended up with a short cycle. So this might explain why we see these different patterns. And going along with this, one study found that the circulation time was the only predictor of the cycle length in Cheyne-Stokes respiration when they looked at different other sort of factors that might have a role there. And so why might these two chemoreceptors be having a different effect? And again, one is responding to the PO2 and one's responding to the pH. But if other things are going on in the body, that conversion may not be the same. So a 7.4 pH may not be a PCO2 of 40 if other things are off. And one of the big things that can be off is if the oxygen is low. So then if the oxygen is low, the pH is less acidic for any given PCO2 level. And so you're going to have this differing, triggering of these two receptors. So that might be one of the reasons why this happens. And so finally, and that's sort of the mixing gain idea. So the controller gain is sort of how much of a response you get per sort of CO2 change. So the chemoreceptor responsiveness is a smaller CO2 change leads to a bigger ventilatory change. So again, if someone's very close to the apneic threshold, then it won't take much of a change for them to go into the central sleep apnea. And people with CHF tend to have sort of this increased responsiveness. Sensitivity is sort of close, but it's basically a larger ventilatory change for any given CO2 change. And if you look at these sort of curves here, if you have things like acidosis or lower PO2 levels, you're more likely to have a high chemo sensitivity and more instability. Whereas if you have, if you're under anesthesia and other things, you're going to have lower chemo sensitivity. So again, all these aspects can sort of come into play. And there's other things where CHF can, increase these tendencies to have this instability. So oxygen, again, this is a list. I'm not going to go over all these things, but highlight some of the few. So those changes in chemosensitivity that we just talked to that are more with hypoxic, if you can make them less hypoxic, that might help stabilize. Oxygen, may sort of lower those resting CO2 levels to keep people away from their sort of apneic thresholds. Changes in sort of the hypoxic drive to breathe and stimulation of ventilation can all be kind of, subsided if the oxygen levels are more stable. This was an interesting study that kind of said, who does oxygen help? And what they found was these people that had these high loop gain properties were the ones where oxygen improved their AHI, where if people didn't already have this high sort of chemoreceptive and other responsiveness, oxygen didn't make a big difference in the loop gain. The other thing that often helps or worsens a lot of people with central sleep apnea is position. So we often think of obstructive sleep apnea worsening with position, but I've seen, even more dramatic cases of central sleep apnea being really responsive to position. So a few studies have looked at why this might happen. One found that if the FRC was lower in supine, that correlated with worsening. Another study did not find that rostral fluid shifts correlated. And then another study that looked at CHF patients found certain things like older age and BNP and the circulation time to make them more likely to have positional OSA, whereas if they had lower EF, they were less likely to have positional OSA, I think because they were just bad all the time. And so less of a difference between the two. So that's your little, why do we have central sleep apnea? So we're going to kind of move on quickly to recognizing central sleep apnea and the problems we have with our current system. So central sleep apnea can look very different. I put a few examples here. This top example, the person's having central apneas. Now, one thing, this can trick people because you still see these bumps, and it's important to notice they're going much quicker than the respiratory rate. So this is cardiogenic sort of pulses. So it's important not to kind of confuse that and think there's still, sort of efforts or breathing going on there. This one, is a nice periodic pattern, but essentially is only hypopneas. So, a lot of people will miss this because they aren't getting that full clear-cut central apnea. This bottom one is a person that's actually on like a BiPAP ST machine, but you can still see this rhythmic pattern, but where there's basically, essentially this is the apneic part, the machine is kicking in, and because it's a machine generated breath, it's a very square wave. And so that can be very easily, mistaken by, technologists or by doctors as being an obstructive event versus a central event. And so one of the issues is our scoring is essentially biased to obstruction. This is mostly taken from Dr. Thomas, so his feelings on this. But overall, we rarely, really score and point out periodic breathing. If there's mixed apneas, which is often the case, we consider those more in the obstructive family, so they don't meet criteria for getting treatments for central sleep apnea. Flow limitation, which often occurs with central events. As you get less effort, it also tends to cause more collapse of the upper airway. So even if central is the main driving factor, as soon as we see that flow limitation, we tend to mark them as obstructive. The central hypopnea criteria, which is basically that you don't have snoring, you don't have flow limitation, and you don't have the paradoxical breathing, is really inadequate. It doesn't, you have a lot of events that again have slight obstructive features, but it doesn't sort of fully pick up all the events that have sort of a primary central nature. And a lot of, labs don't even score it at all. Central events tend to have a lot less DSATs. So if you're needing DSATs, you may not be able to score a lot of these events. And then, for the criteria for central sleep apnea, it requires having central apneas, which some patients never have any central apneas. And then, to have 50% of the events being central, if you don't even then mention that there's this sort of central tendency, you're not even going to be thinking about it. And then when we're qualifying for treatment, not only do we have to get the central apnea over 5, but we have to get the obstructive index less than 5. So it's not even that 50% of the events are central. So especially if you're not scoring the central hypopneas, it can be nearly impossible to meet these criteria. So what I would really encourage people to do is, instead of thinking of any one event on its own and trying to decide, does this meet central criteria or obstructive criteria, is you really have to look at the big picture. What is happening? Is it worse in REM? Is it worse in non-REM? Is it getting worse as you're going up on pressures? Or is it getting better? How symmetric are the events? You can have centrals that aren't symmetric, but often you'll see the symmetry, and as you go along, it becomes more and more obvious. If I start seeing a patient that late, on higher pressures, have clear centrals, I'm going to look back earlier in the night and look for, were these questionable events, starting to have more periodic stuff? And that's going to really help me with not over titrating, because I might realize that, looking back, I think it turned mostly central, back at CPAP 8, even though they titrated up to CPAP 16. So when I switch over to other treatments, I'm now going to start with a much lower EPAP. One other big thing is what the oxygen pattern does. So because especially rhythmic centrals are happening at a very equal rate, and they're very self-similar events, their DSATs tend to be very similar. So really looking for this pattern of oxygen banding, where you have these sort of usually small but very sort of rhythmic events, is going to help you. I like to talk about a reverse REM period. So if you're doing a home sleep study and you don't know staging, you can see this patient, they had lots of events and then it kind of goes away, and lots of events and goes away. Probably these periods are actually the REM periods where the breathing went away. Now, alternately, if they have both obstructive and central sleep apneas, it may look like this in the non-REM period, and then you may see the more typical sort of triangular shape, bigger irregular DSATs in those other periods. This is a case that kind of has a mix of both central and obstructive features, but you can see some of these periods where it's looking sort of more even and other periods where it's more irregular. This is another one where you can see again in REM, the breathing stabilizes. And so that's going to also help you. So just quickly, some fancier ways to look for this. Spectral analysis looks at basically your RR rate as well as your respiratory rate, and looking for this sort of synchronization and cycling. And so when you're looking at the low frequency coupling bands, if it's central, you're going to see this very rhythmic, that everything is essentially going, at the same rate, whereas obstructive, it's all over the place. There's long events, there's short events, different frequencies. And so hopefully in the future, we'll have AI and things that are incorporating these indexes, so we can kind of, give sort of a analysis of how often we're seeing these sort of central events. There's some other people that are looking at sort of breath by breath endotyping, and in looking for things like periodic breathing and other things to sort of, again, give a grading of these types of events. And so there's sort of more work in this area that might hopefully sort of change the way we score and mark these. But I think the only way to be successful is for us not to think of this as one or the other. It's really how much of an overlap of the two things are there going to be. All right, so I'm going to spend most of my time on treating central sleep apnea. I want to point out 2012 was the last ASM guideline, essentially said that CPAP and oxygen, adaptive servo ventilation, and BiPAP, those three were the potentially standard recommendations, and then options for other treatments, including like BiPAP ST and acetazolamide and some medications and things like that. So so I think a lot of patients, can benefit just from CPAP, and if it works, great. Some of that might be that you're stabilizing the obstruction there, and just that stabilization, or just that sort of increased lung volume, or things like that will help get rid of it. Often low CPAP pressures work, but I think some people, if they're too low, there's not getting enough air, and that can actually lead to centrals at especially sleep onset because they're kind of, going, I need more breath, and that gasp sort of will do it. I see a hand up. If we can hold it to the end, I'd appreciate it, just because I have a lot of stuff and it might get to it. Um, so again, we kind of mentioned before that as you go up higher with CPAP and BiPAP, we tend to get an increase in central events. And likely one of the big causes is that we're increasing the hyperventilatory disturbance. Now you got to remember, if our body thinks our CO2 is, one level, and so that means we should take a certain size breath. If you have a machine blowing air strapped to your face, when you go to take that breath, it's going to be a different size than you're, maybe expecting. And so you might increase that hyperventilatory disturbance. This was a bench model that basically showed if they made a big hyperventilatory disturbance, you got this sort of instability afterwards, where if the hyperventilatory disturbance was lower, you didn't get as much of the disturbance. And so, so I think this over breathing tends to be what causes the under breathing. And so if you can get rid of the over breathing, often the under breathing goes away. I do not like BiPAP ST. I don't use BiPAP ST. And I don't think it's the right treatment of choice for periodic centrals. It may be fine for rhythmic centrals. However, I would argue that given it has the same insurance code as fancier machines that can do more, like the VAPS machines, you might as well get VAPS, and you can always set it to a BiPAP ST setting if you really want to do that. But what can happen is you got to remember why, the Cheyne-Stokes happens and the centrals happen. So at the beginning of the central apnea, your CO2 is the lowest. So your body is saying, I don't need to breathe because my CO2 is lower. And it's not going to start initiating a breath again until that CO2 builds up. So if you force a big breath during that apnea, you're driving your CO2 down lower. And what you'll often see is the length of the centrals becomes longer. And so it may correct the oxygen, it may stabilize the breathing some, but if it doesn't kick them out of the cycle, then it doesn't work. Now, some people, just by stabilizing the oxygen, just by improving CO2 levels, it will stabilize. So it's not that it never works, but you really want to see not just that you got the oxygen better, you want to see that they really, get into a pattern where the central fluctuations are gone. And so again, these fixed machines are sort of assuming that the breathing is the same throughout the whole night. And so you have two main sort of breathing disturbances. You can have breath to breath changes like the periodic breathing, and then you can have breathing changes that change throughout the night. So it gets worse in supine position, gets worse in REM. And so if you need a really different pressure in one part of the night than another, or with one breath compared to the other, these fixed settings just don't do well. And so that's the sort of goal of these more adaptive machines. You want to, especially for obstruction, give enough pressure to clear the obstruction, but hopefully in the periods of the night and non-REM and things when you don't need as much pressure, you want it to be a low enough pressure so that you're not triggering off the instability or other problems like mass leak or hyperinflation. Now, a lot of people, centrals can clear on its own, and obstructive sleep apnea, can cause that sort of high loop gain, with the increase, sort of hyperventilation after arousals and awakenings, and more sympathetic, sort of, responses to the low oxygen. If you can stabilize that, the breathing, may improve. And so, for a lot of people, once they get on CPAP, the percentage of centrals will go down. So again, different reasons for this. I'm not going to go too much in it, but increasing that lung volume, reducing that sort of sympathetic and sort of ventilatory over drive will often help. So how often does treatment emergent central sleep apnea happen? So a study by Zinchuk, don't know if he's on the call, found that about 5 to 10% of people with sleep apnea are treated with CPAP. Now, they found about 50% went away, but they also found that about 25% it stays around, and that some people go in and out of it, and that it can happen later with CPAP. So, there still is a lot of it, and different, factors, whether people are on their side, whether they're on different meds, whether their heart, is changing. All these different things can sort of change a person's risk for their sort of central sleep apnea over time. So typically when we're kind of evaluating patients, we're often looking at their adherence data and looking at this residual AHI. And then when we look at it, we then look at the centrals and obstructives. In general, if the majority of the apneas are central, I assume that, okay, it probably is a central problem. And, maybe I want to go down on the pressure or consider another machine. If the majority are obstructives, I'm going to go up. But you got to remember that hypopneas are not evaluated differently by these machines. They do not know what a central hypopnea is. So all hypopneas are considered obstructive, which means it's going to follow the obstructive rules to go up on pressures. And so, I'll assume that if, there's more central apneas, that probably whatever hypopneas there are, those are more likely going to be, whichever is the predominant event overall. Now, you don't know for certain, but it's a good guess. Just to review how it determines the central sleep apnea. So essentially, it does what's called the force oscillation technique. So if it picks up that there's essentially no airflow movement, in ResMed's case, 2 seconds after, it senses that it's going to start doing this very small oscillation of the pressure, a 1 centimeter oscillation pepper. If any of you have CPAPs, it's kind of fun to hold your breath, and you'll feel that 2 seconds afterward, you'll feel this like vibration. That's what's going on, is it doing this little test. So if your airway is open, basically the pressure disappears into the lung and it doesn't get picked up by the machine. If the airway is closed, the pressure sort of goes back to the pressure sensor in the machine and it picks it up, and it'll call it that. So it's fairly good, not perfect, but it's fairly good at differentiating the apneas. Now, again, no differentiating of the central events. So as I mentioned before, most events end up being mixed. Some look perfectly pure centrals with, no flow limitation, and are beautiful and rhythmic. But a lot of times you're just going to see that there's this sort of, semi-rhythmic pattern, that it's worse in non-REM, worse in REM, but you still might have snoring, or the snoring might be, just signal from being on a PAP machine, that can make it hard, especially once you're on a BiPAP or a VAPS machine or an ASV machine. The kind of square wave can kind of cause a flow limitation shape. So you really want to be looking for these things, like, is it, totally go away in REM? Is there a nice symmetrical thing? Or is it getting a lot worse as you're going up with higher pressures? Where are the arousals? Are they sort of mid-event? And is there sort of a, crescendo, decrescendo pattern? So the other common one I see is little pauses in the middle of the breath. So it's kind of not hitting full apnea, but you'll see that the respiratory rate is sort of slowing in that nadir of the effort. So, not only is it hard for our techs to appropriately score these, but again, the machines are not picking these up as, central events if they are. And so just as a reminder, if you're on an auto CPAP or, an auto ASV, if it thinks there's a hypopnea, it's going to go up on the pressure. And that may be exactly the wrong response you need. So I tend to avoid auto settings for people with a large central component or have a very narrow range of pressures that they can go to. Want to just bring up a sort of sample case that I got. This was a person, they called in, their usual residual AHI was around 3, and suddenly it was around 60, and we did a sort of download of their data, and they were having just this recurrent short cycle centrals one after another. So interestingly, this person had flown to Denver for the week, and this was his altitude-induced central sleep apnea. So just to keep this in mind, I sometimes warn my patients who I know are going to be traveling out west or to other places that this might happen. He did go back to normal basically the day he came back home. All right, so if you do feel they need something more than CPAP, and we're thinking of these advanced settings, again, you have the fixed BiPAP ST, which is always going to do the same EPAP and IPAP throughout the night, or these more adaptive versions. So servo ventilation, I like calling it servo ventilation because ASV is specifically ResMed's device. Is either going to have a fixed or an auto EPAP. That EPAP changes just the same protocols as the auto CPAPs have. So if it sees obstruction, or what it thinks is obstruction, it's going to go up. So the biggest difference is that the amount of pressure support is going to respond to the recent volumes if it's a Respironics machine, or ventilation if it's a ResMed machine, and its goal is to try to stabilize the breath. So ResMed is targeting 90% of recent minute ventilation, essentially the last 3 minutes. And it does these very fine adjustments all throughout the inspiratory cycle of the breath, every 1/50th of a second. Respironics is a much slower, clunkier sort of response. Basically, it assesses where the volumes are at the mid breath point, and if it's lower than it wants, it'll go up on the pressure support, but with certain maxes, like it'll only go up by 1 at a time. If it's too high, it'll wait for the next breath and give a lower pressure support for the next breath. So it's a much slower response. It does have a second sort of thing where it looks for a periodic breathing pattern, and if it senses if they're in a periodic breathing pattern, it'll try to go up on the EPAPs to see if it gets better. If it does, it'll stay up. If it doesn't, it'll go back down. So they work quite differently. Don't expect that one will work if the other will work. You cannot just switch and assume that one setting is the same setting. I want to bring up with adaptive servo ventilation, the two big studies. So the SERV-HF study from 2015 basically showed more mortality in patients in theory with an EF less than 45%. And the ASM came out with a warning to not use if the EF is less than 45%. Of note, with moderate or severe central sleep apnea. There is no recommendation against using it in people with obstructive sleep apnea at baseline. And so there were a lot of issues with this machine. There are protocol violations. Not everyone had a low EF, and there were differences between the arms. There was a lot of people with missing data. There was suboptimal randomization. There were a lot of crossovers. One thing that really bothered me is they had the residual HI on average was 7, and there was a huge range. The average O2 was 19 minutes, still below 88%. So I really don't know that they got people on the right settings. This was also the older ASV model as opposed to the newer ASV model, which has a slightly different protocol. And then just with some of the sub-analyses, they really only found increased mortality in those who had an EF less than 30%. And if you actually had primarily obstructive sleep apnea baseline with less than 20% of Cheyne-Stokes at baseline, you actually had lower risk of mortality, even if your EF was low. So again, there were some suggestions, especially with the majority of patients that are OSA with treatment emergent central sleep apnea, or if they were in this higher range of ejection fraction, that it would be potentially okay. And many of us, had many patients who were on this before and, feeling great and doing great. And did you want to take them off of something that was working so well for them? We have new data, Lancet this year, the Advent HF study tried to sort of almost recreate some of this. And they basically did not find an increase in mortality. I hear ASM is expected to do an update of their recommendations, so we'll wait to see with that. So no improvement in mortality, but it did improve AHI and sleep quality and symptoms in these patients that were on ASV. What I learned from these studies is you want to use ASV carefully. ASV does not always work. Sometimes it leads to what we call pressure cycling. So if you don't kick the person out of ASV and it's always responding with doing high pressure support, then low pressure support and high pressure support and cycling all night, that probably is a lot of stress on the patient. So a good response to ASV is when the breathing looks normal. A bad response is when you, quote, fix the apneas, but you haven't gotten them out of Cheyne-Stokes, especially in these effort bands, you're still seeing this variable response. And you can also see this on the detailed data of your adherence data. If you see big changes where sometimes the pressure support is 15 and sometimes the pressure support of 3, you're having this cycling, versus if if it kind of, as you fall asleep, goes up, but then it stabilizes out and it's not really needing those high pressures, that's probably doing better. So I think that is important to sort of follow these patients closely and look for these responses. Another issue with ASV is when you're in the ramp period, you're essentially on a BiPAP machine, and some people BiPAP really worsens the centrals. So if you have a high residual AHI, again, you can look at the detailed data and see where are the events still happening. And in this case, they were essentially all happening in the ramp period. And so if you can shorten or get rid of the ramp period, you might be able to get rid of these untreated events. All right, and then volume assured pressure support is also doing, it's basically an adaptive BiPAP, but the way it changes its pressure support is to get to a goal that you put in. So for Respironics, you're putting in a goal tidal volume. For ResMed IVAPs, you're putting in a goal estimated alveolar ventilation. And these are really good for people where sometime of the night they need like a big pressure, like in REM, but in non-REM or lateral sleep, they need a lot lower pressure. So you aren't sort of over titrating them and inducing those centrals or causing other intolerance issues. IVAPS essentially works just like ASV, except for what it's targeting. AVAPS, again, a different, slower target, but it will, if it's below its target, it'll go up essentially 1 centimeter per minute. If it's stable breathing, half if unstable breathing. Now, if you have the trilogy with the AE mode, you can change this so it can increase quicker. But if you think about it, if you're in non-REM and you're at 10/5 and suddenly you go into REM and you need 20/5 and it takes you 15 minutes or even 3 minutes to get to the pressures you need, you are under treating them. They might have already woken up. They may have already desatted. So IVAPS is a sort of much more sensitive machine. The other thing that's different from the machines is the backup rate. So the IVAPS backup rate, you put in, let's say 20, when they're spontaneously breathing, it will drive the breathing at 15. And so that potentially is better for tolerance, sort of not over breathing them. But what it does is in the central apnea period, it will gradually increase that to the set volume. And because it's trying to get to a ventilation, that means if you have more breaths, it's smaller tidal volumes per breath. And that can be good for not over breathing and sort of having that sort of hyperpnic response that might worsen the central sleep apnea. So it sort of eases them out of it a little. And so that can be better potentially for some patients. There was one bench test that looked at these devices, and they found more concerning responses with Respironics, only an acceptable response to central hypopneas, and a really unacceptable response for obstructive hypopneas and obstructive apneas. And this is also true for the auto CPAP device. It can take 5 to 10 minutes for a Respironics device to respond to apneas and hypopneas. And so again, I think you can get better control for a lot of patients with the IVAPs. It is also now what's available, so that can be good. But it is important, again, you cannot just switch from one setting to another. It's really important to see how they do. One IVAP setting can look horrible, another IVAP setting can look great. So if you have them on the wrong setting, you might get a totally different response. This was a patient, they had obesity and CHF and diastolic heart failure, a little of everything. Again, with bypass T, with 4 liters of oxygen. I don't know if you can see it, but the oxygen was still in the 80s. There was still this cyclic pattern. I think the CO2s were up at like 57 to 62. So really the suboptimal response. It got looking somewhat better with the AVAS, but you can still see the machine is kicking in here. You're still having this rhythmic response. And this person, their numbers were sort of better. Their AHI, residual AHI was fairly low, but they didn't feel well with it at all. We then brought them back and tried them on IVAPs with a much lower oxygen level, and we got higher oxygen levels, lower CO2 levels, stable breathing. So this is what you want to see. That is a good response. This is not what you want to see when you're titrating people. So just quickly, kind of how we titrate these people. I always want to think of, opening up the airway. So find that EPAP, find that CPAP level that opens up the airway. If despite that, there's still hypoventilation, you want to think about BiPAP. In some people, you can use the trigger and cycle and those things if appropriate. If that's not doing well enough, then considering VAPS therapy. If they have hypoxia due to hypoventilation, you want to try to fix the hypoventilation first. You might need to add oxygen, and then if you get the hypoventilation under control, you may be able to pull back on the oxygen. And if there isn't hypoventilation, you potentially want to add that oxygen in earlier. If at any point along the way, your treatment is limited by centrals, now we're thinking of switching over to these adaptive devices like servoventilation. I do the SV if there's no hypoventilation, and we usually go first to VAPS if there's hypoventilation. So SV, because it's targeting a 90% of recent minute ventilation, you tend to get higher CO2 levels on it. So if the CO2 is already higher, that can worsen it. Other options, if the CO2 is low, we may consider end expiratory rebreathing space, which I'll touch on later, acetazolamide. And even if the oxygen is okay, oxygen can sometimes stabilize these patients, but you got to think about, can you get it covered, or is the patient willing to pay? I just put up these little images as reminders. We had to add ASV and IVAPs to our little titration model so that all these settings could be marked appropriately and get onto our reports. So you can add these manual extra settings in so that you can make sure you give the right information. So more complex of sort of how to move through these. I have little COPD and CHF, pathways, but basically, are you seeing obstruction? Are you seeing CO2 levels? What are you seeing with the O2? Putting all those things together and kind of working your way, through these different machines, and then along the way, making sure you're meeting the insurance criteria. So essentially, at least around where I am, I can't even get the people to cover it if there's central sleep apnea at baseline. I also have to show that there's still central sleep apnea despite BiPAP. So I have to try at least 2 CPAP levels, at least 2 BiPAP levels. On the highest BiPAP level, I have to have at least a central sleep apnea index of 5 and an obstructive sleep apnea index less than 5 at the same time. That is essentially how I get all these machines. Hypoventilation criteria is essentially impossible to get, so I don't get that. Occasionally, if they have another diagnosis like COPD, and you can go straight to a vent, but obviously those are much more expensive. So most of our patients were using this sort of middle criteria there. So quickly, don't have too much time left. So end expiratory rebreathing space, the goal is to bring up the CO2 levels. So essentially you have a non-vented mask, some extra tubing, which is the dead space, the whisper swivel valve, which is where the air actually leaves. So instead of coming out of the holes by the mask, it's now leaving farther down the circuit. So you're rebreathing in anything that's above that circuit. You want to have the bell pointed outward. And then that connects to the tube and to the machine. So it's really simple to use. It's really simple to titrate, and it can have amazing responses. These are some of Thomas's examples of someone who just, it wouldn't go away. You put on the dead space and it melts away. Here's another one, ASV. They were still cycling. You add in the dead space to the ASV and it melts away. This was a really severe case I had recently. This woman for 20 years had just horrible sleep apnea. She'd been to other doctors. She'd been tried on CPAP and BiPAP and BiPAP T. Nothing worked for her. Essentially, the second she would fall asleep, she'd have these severe central apneas with DSATs down to about 50. And we tried her on things. You can see here again, BiPAP T causing these like 3-minute long apneas. When she was on IVAPs, I think we got up to a 4-minute long central apnea. And so we brought her back because what we noticed was her CO2 levels were like around 31. They were really low. So we're like, well, let's try dead space. And so we did have some points where ASV with dead space and oxygen looked very stable. What we ended up ordering was CPAP 5 with 150 cc's of dead space and 1 liter of oxygen. And she's now been on it for like a year or so and has been sleeping for the first time in her life and feeling better. It really can work sometimes when other things just won't. Acetazolamide, kind of the same theory. You're bringing up those CO2 levels. So I always consider it in patients that have lower CO2 levels. I like it for people that have a lot of the sleep onset events. Usually I'll try like 125, maybe go up to 250. Don't always, but sort of max would be like 500. It either works or doesn't work. You can try it out in the lab, or you can just, I'll often give the patients, be like, do you feel better? Or does your residual AHI go down? And things like that. People can get tingling in their fingertips, metallic taste in their mouth, but usually tolerate those low doses pretty well. And you do want to watch out for like kidney stones and things like that you might worsen. There have been some meta-analyses that do suggest that acetazolamide can work. So there's a decent amount of data that it may be worth a response. Sleep stabilizers. I think this has the most efficacy in people that have stuff right at sleep onset. So if you're having very fragmented sleep and you're seeing that they have just tons of awakenings, if you can kind of stabilize that sleep and not have this, sort of re-wake, get, above and below the apneic threshold, you might be able to get rid of them. I really only use it in non-hypoxic people. So if they have big oxygen drops, I'm not really, fair about this. Again, you can just try an agent and see if it helps them feel better and sleep better, and numbers go down, or you could bring them in for a sleep study and, and watch them do it in the lab and see if it's better. So I don't do a lot of this, but sometimes if the sleep is really fragmented, I can consider that. Phrenic nerve stimulation. This is basically stimulating the diaphragm to move when it's not moving. Essentially, the criteria is that you have to have at least moderate and central sleep apnea, with hopefully most of the events being central apneas and not having much obstructive sleep apnea. In the studies, majority of patients had improvement, about 60% was sort of marked improvement, and a small amount that did not do better. It has lasting response over time. The main events that don't go away are the obstructive events. So you really, do want to get people that have mostly central sleep apneas, and also you can see that the hypopneas didn't, go down by that much. So you really want to preferably think about people with central sleep apnea. Few last topics, just medication-induced sleep apnea. There was a recent review in Sleep. And so just important, not only the opioids, but your cousin opioids like tramadol, but baclofen, gabapentin, your oxybates, valproic acid, Tiglator, so there's a bunch of these agents that you want to think about. And, I mean, we often don't think with our narcoleptics who put on, on a sodium oxybate to bring back in the lab or do a study on. But, certainly keeping these things in mind. Obviously, if you can get rid of these meds, great. If you can't, consider, do you need PAP? Do you need, some other treatment to help them? I think of all these again as hypoventilatory states. So even though there are data that ASV helps, I tend to pick VAPS first. But if VAPS doesn't look good and ASV does, I'll certainly do that, especially if the CO2 isn't an issue. Another study I found was clonidine. Not something I've ever used, but it is out there. Last, since I have to talk about advocacy stuff, a few years ago, there was a committee that was supposed to give Medicare recommendations of what to cover for NIV devices, and essentially, talking about how central sleep apnea is kind of the poor stepchild, and has these crazy criteria. So we wanted to basically have the criteria for it mimic OSA criteria. This isn't necessarily the best, criteria, but we thought it was maybe something they would go for. Right now, there's actually, it states you have to have hypoventilation, which again is not the case in a lot of people with central sleep apnea. And we really thought that they should cover not only these PAP devices, but the backup devices. And because these all have the same codes, if someone gets put on an ASV and it doesn't work, and now they need to be switched to IVAPs, you essentially can't do that. So we'd really like that ability to be able to switch between the devices if testing shows that that's needed. And again, to at least follow the continuing coverage like it is for OSA, which we did ask for changes for. Medicare did not take up any of the suggestions from this committee based on central sleep apnea or any of the other things. So it's definitely something to still sort of push for better coverage. So finally, just key takeaways. Most of the central sleep apnea is mixed. Our current scoring system isn't good. Periodic, think cardiac, check your echo. If it's irregular, think the brainstem and medications. And if you look for certain features, it may guide you to what type of treatment might be better. If there's, low CO2 levels, you might, be thinking of the dead space or the acetazolamide. If it's supine dominant, maybe you can treat it with just positioning and different things like that. And then treatment wise, again, you really have to score central hypopneas or you're never going to qualify for these machines. Really watch out for over titration and sort of under recognizing these quote central hypopneas. And often you're going to start pressures low, try not to use the EPR, try to, limit the auto. If you can get that oxygen, it can certainly help. ASV probably is okay in people with low EF, but do, watch them closely that they're having a good clinical response to it. And then we do have some other things with the phrenic nerve stimulation and sleep stabilizers. And again, please help advocate for improvements in our scoring and coverage policy. So I think I'm over, but I made it. Any questions I can answer if anyone can stay around?
Yeah, 1 more minute. Thank you so much, Dr. Johnson. This was a very detailed, thorough, and an excellent talk on this really challenging topic. So thank you so much. I don't have a lot of questions. I had a quick question, but that's more like a practice-based question. Let's say you have a patient, who has treatment-emergent central apnea. You've tried VAPS, you've tried BiPAP ST, you don't have option for dead space, but has EF of 30 to 45%, given that SERVHF did not have severe sleep apnea patients. Would you consider ASV or
So I never stopped considering ASV for treatment emergent central sleep apnea.
okay.
In theory, even the advice from ASM was that if they had moderate to severe central sleep apnea, and so if they have primarily obstructive at baseline, the data from that study suggested that those people did well. Now, you still should do it with caution, make sure they have a good clinical response to it. If they're telling you, I feel worse using it, maybe don't keep pushing it. But, if they go, oh my God, I'm a new person, I feel so much better, I'm sleeping well through the night, I think the chance that you're hurting them is very low, and especially with the new data from Advent study, I think you can feel really confident about it these days.
Perfect. Thank you. Let's see. So there's Sophie who says, can I have a
So there's a brain imaging question. I do it when I don't have other reasons. If I know they have CHF, I'm probably done. If I know they have AFib and it's nice periodic stuff, I'm probably done. If they're a weird age, if they're really young, if they're it's a weird pattern, like it's in REM, it's just so severe with big huge DSATs, like things that make it a more atypical pattern, that's when I'm gonna want to get the imaging. But if it's kind of have a good clinical picture and in the right scenario with a good other cause, then I probably won't. And then in theory, you should do a neuro exam. And obviously, if they have any other abnormal neural findings or history that's suggestive, then I might.
Perfect, thank you. And there is someone who might be a fellow. It just says, thank you for this great talk. Any online resources on interpreting ASV and advanced PAP mode titrations for fellows education?
I'm going to be giving talk to you guys in 2 more weeks to go over it more. I have a sort of titration guide that I share with people, and I'm happy to share. ResMed provides some stuff, and they will come out and give lectures to people that if needed. So those type of things, but online resources, not so much.
Not much on any of the Francois says, wonderful talk. Thank you. Joyce from University of Arizona, amazing and useful talk. Thank you so much. Thank you so much. We're over time, but if people have to leave, you're welcome if you want to stay. And if anyone has any other question, you guys can unmute yourself and
I'll send
the slides
the slides over
to
and
Debbie, and then
and
Debbie
you
could
can
send.
email
Yeah.
me or
Yeah.
text me anything if needed.
All right, I don't see any further questions, and I don't see any hands, and no one's unmuting themselves. So that was a great talk. Thank you so much, Dr. Johnson, and thank you so much, everyone, for joining in.
Thank you for having me. Sorry for going over.
That was perfect. You covered it right on time.
I didn't know what to cut.
2:59. All right. Thank you so much, everyone. Bye-bye.
Thank you.
Bye.